Good evening, everyone. Thank you for joining us on this wonderful evening. Apologies for a few minutes delay, but in any case, I think we might get started. So thank you once again for joining us in this October session of the OTAC clinical case webinars. It feels like the year's going very quickly. This evening we have Professor Demirkol, who will be working through some cases focusing on chronic pain management and the intersection with that and OAT. So Apo is senior staff specialist, I believe, at Drug and Alcohol Services within southeastern Sydney, and he also does a clinic at the Prince of Wales Hospital Pain Management Centre. And as Apo and I always joke, he is on the dark side and he doesn't work at USyd. He is based at UNSW, but we certainly won't hold that against him. And nothing wrong with a bit of academic collaboration in any case. But without further ado, I would like to make an acknowledgement of country. So I'd like to acknowledge and pay respects to the traditional owners on all the lands that we are meeting this evening. I am joining you from my workplace based in Camperdown, which is on Gadigal land. I extend that respect to all areas across this country where you are joining us, and pay respects to elders past, present and emerging. Wonderful. Just very quickly, because it's always interesting to see who joins us. This is the registrations for this evening, as you can see. Had a bit of an uptake of regional representation. Usually it's in the mid to high 30s, so great to see breaking the 40% mark. So anyone joining us in regional areas, wonderful. And just very roughly as well, who's registered for night in terms of their sort of broad role. Wonderful to see we've got a lot of GPs joining us, but we also do have representation from a whole other series of roles. And at last check, we had over 140 people who have registered to join us. Just very briefly as a reminder, so we use these webinars as a sort of mechanism to, focus on specific topics related to OAT. And, we always encourage you to ask questions, interact with the polls, and also to submit any cases if you have any in particular. And we were quite fortunate with this session that we had a few individuals who did submit some cases previously. So we were able to actually work off them as a basis for some clinical case discussions this evening. Next slide, Apo, thanks. I think many of you have been here before, but I'll only briefly touch on some of the housekeeping. Probably the main one is if you are on mute, please be on mute unless you're sort of speaking or asking questions. Particularly if you are speaking, it'd be great if you are able to put your video on. And we very much encourage you to unmute yourselves to, make points or discussions throughout at appropriate times. We do, of course, record these webinars, so please try not to reveal any identifying information if you are referring to a specific case. If that does occur, we can always, redact that from the recording, but just try to be mindful of that. And the final point to really drill home is if you think you have a conflict of interest, such as if you are a pharmaceutical company representative, we do ask that you please sign off and not join in these webinars, as they are only geared towards health professionals and those who work within the health settings. Wonderful. And as many of you know, this is very much built on case discussions, so we'll largely focus on them. We do have little portions of didactic pieces which Apo will be discussing with others, but you may want to have, a pen and paper or your electronic notepad, or but be prepared to, be involved in any online discussions, activities and polls, etc. But without further ado, I will pass over to Apo, who will take it from here. Thanks, Apo.
Thank you, Daniel, and thank you everyone for joining. I can't believe that 54 people thought that this is the thing to do on a on a Wednesday evening. So I'm grateful and humbled, and also I'm sort of nervous because I'm not sure that there is really a clear-cut answer to anything. But I just want to mention that I can see the level of expertise in the room. In fact, one of my colleagues from the pain team is here. She's a pain physician, Dr. Woolman. So, this is opportunity for all of us to discuss. I don't know that I have anything more than you would have in terms of managing these very complex cases. And as Daniel mentioned, we've incorporated some of the cases to here, and those who submitted, thank you. And if you think that it's modified, it's just for really, if you like, artistic purposes, because we have limited time and we want to make sure that this sort of works in that way. So Thomas is our first case, a 48-year-old man. He's been on methadone, 90 milligrams daily for 3 years, pretty stable. Drinks 3 times a week, consumes 3 to 4 standard drinks on each occasion, no other illicit or illicit drug use. So this is to say that he's quite sort of stable from drug and alcohol point of view. He's a chronic back pain sufferer, and the way that it was managed to date was non-steroid anti-inflammatories and some low-dose amitriptyline Nocte. And it was taken to hospital after a motor vehicle accident, sustained a fracture to the left radius and 2 ribs unilaterally, and sort of stayed in the short stay admission, and oxycodone 10 milligram TDS was utilized, and in response to the acute pain, and cleared medically, and respiratory system not compromised. I guess this is one of the important issues in it when you have someone with rib fractures. There are multiple comorbidities that you need to think about, and I guess one of the issues is if their respiratory system is compromised, then you may need to think about whether you need to do something about their OAT, but it's not the case in here. So they sort of thought that he should continue with oxycodone for 5 days post-discharge and before ceasing, and that he is given 5 days supply of medications on discharge. Sharon, I can see that you put your hand up.
Yeah, sorry, and I put my hand up. I was just going to say, to encourage everybody to please write any comments or questions they might have in the chat, or if they're keen, put their hand up and throw your opinion in.
Yep, thank you. And Sharon is going to help me. Sharon and Daniel are going to help me to go through these questions, because I might not be able to see what's written there, and but you're more than welcome. So that's basically our scenario. So I guess my first question is, it's obviously open-ended question. How would you go about managing Thomas's pain post-discharge? So you are, I think the assumption here is you're either the GP or the prescriber, but you're involved in the care of Thomas. And I just want to tell you that there's not a right or wrong answer. So please feel free to put in the chat what you think you would do in responding to Thomas's pain post-discharge. So he kind of stayed in hospital a couple of days, and the hospital said, keep on taking these medications for 5 days, and provided him with supply of these medications. Should she take the medication, stop the medication? Can you think of anything else?
Yeah. And I guess that's the other thing is, are there any other, anything else you'd do for his pain besides the medication? Lucinda's written, in consult liaison, it's frowned upon to have dependent patients discharged with opioid analgesia, and another authority is needed.
That's a good point, Lucinda. If it's dispensed from hospital, that authority requirement is not there because it's a hospital medication. But if an ongoing script is required, so you kind of stole my thunder, that is, that's going to be an issue about how are we going to go about it. And I can see some responses already coming up. And
yeah, one says try and change the opioid, perhaps increase the methadone dose.
Yeah. Okay.
And one's thinking, Andrew Moore says he's thinking that this could be an issue for his pain for another 4 or 5 weeks. I'd probably increase the methadone.
Yeah.
Someone's suggesting using tramadol, 50 to 100 QID, PRN.
Yeah. Yeah.
Thanks for clarifying. So thanks for clarifying, as many teams will not order this as per AOD CL. Others are agreeing with the idea of increasing methadone. And Ignatius says, maximize non-medication, split dosing of methadone, slightly increase methadone for a short time. Can consider atypical opioids, but depends on this particular state you're in and the permit for that.
Yeah.
A lot of people are favoring the split methadone.
Yeah.
And Alison suggests lots of NSAIDs, and Luna suggests consult with a pain specialist.
Yeah. And I think all of these are quite valid. Consider acupuncture, so non options. So and Luna, that's a good question, splitting methadone dose, and we'll talk about that a bit down the track. But I think it's a really good sort of suggestion. So, look, I think they are really fantastic suggestions. In terms of this, I guess with the I think there are several issues that we need to think about here. Does he have a sort of valid pain, sort of that would acute pain that would require and benefit from extra medications, including opioids? Because everyone, those especially those who are on opioid maintenance treatment, everyone deserves a proper pain relief, and especially in this group, if pain is not properly managed, there are increased pain behaviors, or they might use their stability might be affected, because remember, withdrawals are associated with pain related experience, and so I think this is this is one of the sort of issues that we need to really make sure that, first of all, Thomas feels supported by us, that his pain is acknowledged, and that we're trying to go and work with him. And I think among the options, so I just wanted to show one way of approaching like what happens in hospital for rib fracture and pain management algorithm. I mean, I don't think there is a sort of fast and sort of established rule, but I think one's age, number of broken sort of ribs and etc., they will be taken into account. But I think for those who are outside of hospital, because in hospital a lot of people are working together. You've got our sort of pain colleagues working, and we've got our sort of orthopods and surgeons and etc. are working. But I guess what I guess all of you talked about is, first of all, NSAIDs are really good, and I think we should really sort of keep that in mind. And it's best to continue with sort of established analgesia. So I'm just going to put him in here, and that we need to follow what the advice was. And can
I interrupt? One of the comments is a bit worried about side effects of NSAIDs.
Yeah, look, I think that's a very good sort of point, and I think you just have to tailor that to the needs of the patient and their vulnerabilities, and I guess the good thing about Thomas that we know that he's been on that, and hopefully he hasn't experienced any side effects for his back pain. So I guess let's do a poll, because there were some people who talked about, before we go into further detail, that we decided that, because I've seen in the comments that people are saying that he would benefit from some oxycodone, and I think we need to put this into context. For how long? And I guess for pain like this, you will just need to. I mean, I'm not sure that 5 days is going to sort of immediately be enough. Oh, it's nicely changing. Please feel free to vote.
So we've hit 50%, so keep them coming in if you haven't answered yet.
Right, that's really good. Almost 70% of people participating.
Give it a few more seconds. Okay, I think we might enter there just to keep the momentum going, and I'll share those results for everyone's knowledge. So we had 55% saying yes in this case, Apo, as you can see.
Yeah, and 30% said no, and 15% are unsure. Thank you very much for participating. So I'm just going to invite Candice. I don't want to take advantage of this situation, but in your experience, Candice is my colleague. I work with Candice in the pain clinic, and we've been working more than I think 5 years now, or for 5 years together. So for a acute pain like this, post-accident, motor vehicle accident, rib fractures, what's the time frame in your mind that they might require analgesia and acute analgesia?
He's only got 2 broken ribs. I imagine the wrist fracture is only going to hurt for a week or 2. The broken ribs can really hurt for 6 weeks.
Yeah.
So I don't know that you're going to get away with just another week of analgesia. So it depends how active Thomas is. Yeah.
Yeah. Thank you very much, Candice. That's those are my thoughts, and I think the thoughts are these sort of thoughts were shared by most. So I think we have several options available to us, and I sort of feel super redundant in here because the options that I had in mind are very well articulated in the chat. And one is splitting methadone, and splitting methadone is about really giving it BD or TDS, and especially for his dose. And but it's quite difficult for someone like Thomas, who's not done this before, to see or appreciate any benefit from that. I think it is important that we explain to our patients, like the methadone as an agent with a very long half-life, that it is a so I'll come to that a bit later. With a long half-life, it's helping with the withdrawals. That's perfect. But in terms of pain effect, is much shorter than its half-life. That is the issue. And I think so. I think it's really important that we make sure that in the initial phase, because I can see Steve saying that it's going to be painful, but at what level, and might be tolerant, and it might be sort of short and sharp for a period of time, and then hopefully that's the idea, isn't it? That's going to be the healing process. So initially we might want to support him and with some additional opioids, but I think splitting methadone, and I've got a case about this as well, might be very helpful. And remembering that most people would find that the effect of analgesic effect of methadone would be better if it's BD or TDS. And TDS is kind of tricky if they don't have takeaways, but with their takeaways and with the current availability of it, I think it's really important that we sit down and explain why splitting is a good option. It doesn't necessarily take away the possibility of giving some further opioids, but I think you just need to do a proper risk assessment, and it needs to be a contract, because anything beyond 6 weeks for any type of pain, it's now moving from acute to subacute to chronic pain sort of domain, if you go by the definitions. And Candice and I, our other colleagues, were having this discussion only last week, really, about how to call subacute pain. This is what we call subacute pain. You moved from acute to and it's not chronic yet. Is it transitional pain? Or because that's what St. Vincent's people call it. But transition implies some sort of will on the part of patient, but I don't think that's the case in here. So I guess during that period, being mindful of that time frame, and making sure that it's time limited, as you would have with anyone who's not opioid tolerant or not on OAT. So I think just using exactly the same principles and setting up an agreement from the outset so that the patient is not really disappointed in that will be good. And I've seen several participants. I'm sorry that because they came in quite fast. I won't be able to name you, but stage dispensing was mentioned, and I think that's really a very safe tool in a scenario like this. I think that that will be sort of helpful. And I just want to remind you all that for anyone who's on or OAT, we need to, regardless of the time, we need to apply for this document that I've got, and the link is shared to you by Daniel. It's a self-explanatory form, and I think in Thomas's case, you got the benefit of his discharge summary, which sort of supported it. And if you can make it time limited, and then if you call PIU and tell them that, like, this is acute pain, it's really for a short period of time, you're seeking approval, not for an ongoing authority, but for a short period of time, you'll find that it's going to be quicker than other authority that you put in for patients with chronic pain. So it takes a bit of time for them to respond to those requests, but a bit like our OAT application forms, if you contact them and talk to them about this being short-term and that it's only for this period of time, that is going to speed the process up and put you in a sort of legally, legislatively, let's put it in that way, defendable place, because prescribing OAT drugs to a dependent person without authority as we speak is seen as a breach of the Therapeutic Act. Lucinda, I know that it is true that hospital teams are not going to do it. You're right. I mean, some teams do, who are sort of familiar with the process, but this is really potentially a matter for the person who's managing pain in the community, whether it's the nurse practitioner or the GP or the prescriber or the pain doctor in the community. But the fact is that anyone who's going to put their pen on paper for further end-on, if we think that's the option. And I think people, and Steve's point was quite valid, we need to assess it. People respond to pain very differently. Some people experience it in a way that it sort of really interferes with their quality of life. Some people are quite stoic, they just move on. There's not one rule that will fit all, and it needs to be definitely yes, it needs to be included in the sort of discussion with the patient. Whatever we're doing is to support them, but also time limited. And yes, I guess Lucinda is with her immense CL experience is talking about something that's really important for community practitioners, and that for those who are working in hospital, it's really important that this information is included in their discharge summary. That is end-ons continued. Would Panadine forward help a patient like this? Not a bad idea. You've got an NSAID and a bit of codeine, and not necessarily an OAT. But Andrew, I would say still you need to look at the sort of limiting it for a period of time, because I think we fall into habits. I'm not suggesting that that's what you suggested, but when we start prescribing S4Ds, that since it doesn't require, technically speaking, authority, we sort of continue with it. Whereas if we go with the spirit of the issue here, which is acute pain, subacute pain, potentially outside, managing outside, I think we need to have a plan from the outset, rather than just becoming sort of being caught up in this sort of cycle. That many community prescribers are caught up. You start with a dose, and the dose just goes up and up and up, and there is no end. And I think there needs to be some sort of structure to that. So that's that. And I sort of talked too much and stole my own thunder. But it was also in the answers. So it's not only my fault, it's your fault as well, guys, because you immediately introduced the idea of splitting Thomas's methadone. But I'm still quite interested, now that we've got this option to say whether we will split it or not. Would you, like, how would you go about that? If you can, please respond to it. All right, we've got 60% of participants, 70% of participants. Majority of people are telling us 62% split. 10% is telling us no, and 30% almost is kind of unsure. And I know why you think no, because it's just like the organizing takeaways are potentially a challenge, but I would still encourage you to think about it, because we have evidence that splitting buprenorphine or methadone, if possible, and if it's taken a BD or TDS, it increases the analgesia that is provided through this long-acting opioid, and that's generally what we do in hospital settings as an inpatient. Someone, if we're managing their acute pain, we split their dose to begin with before we add anything else. And I think to maximize the pain effect when you have a long-acting opioid analgesia like this, and also potentially minimize the amount of additional opioids that you're going to use, I would argue that it's not a bad idea. And but obviously, whether he has takeaways, whether you can give more, the safety and etc. That's something that I guess we need to think about as an individual basis. And I would there's a little discussion going on about Tygen, and I agree with David. I think if we're going to put an opioid analgesia on top of methadone, a full agonist, you might as well bite the bullet and give the real one, because you don't want to take the risk. I mean, technically speaking, it shouldn't cause any withdrawal effect, but Tygen is known to have interactions with methadone, not very common. So if it's time limited, if you think that you need any opioids, probably go with oxycodone, I would say. All right. What do you mean with takeaway doses? That is basically when people are on methadone and buprenorphine and they're authorized to take their medications home. Okay, so I'm just going to move on to, because I'm just seeing Sharon and Daniel's nervous movements, how poorly I'm using my time. So I'm going to move on to the second one and continue with the sort of with that. But I can see that Ignatius saying that it's a bit harsh to ask patients to return to pharmacy 3-4 times a day. That's not what I'm suggesting. It's more about if they have takeaways, to take the takeaway in a split dose and reassure them that they're not going to hang out, because oftentimes our patients have the fear of having a withdrawal experience if they don't take their medication in full at a time that they're used to. I think that reassurance is really important, an explanation as to why splitting the dose will be effective. Okay, I'm going to move on to Roland. Roland is an Aboriginal man, an ex-football player, lots of sporting injuries from his early 20s, no substance use of note. He's been a chronic pain sufferer because of his sporting injuries. Some 5 years ago, discharged from hospital on oxycodone, 300 milligrams BD. But with the sensible approach of his GP, and the pain team, everyone involved, he's now down to 25 TDS. So they did sort of gradually reduce the dose, and they added NSAIDs and also gabapentinoids, as you can see there. And he's got now other issues. So there is radiculopathic sort of changes and associated pain. He's got carpal tunnel syndrome, and you know that he's awaiting surgery. He's got right foot pain, and the dose of his medication, I think whether it needs to go up, what needs to happen is being discussed. Is OAT, opioid agonist treatment, an option for Roland? I guess, that's the thing that I had in here. So would you put someone like Roland on OAT? Right, we're almost 70%, and basically what we have is 38% of people are saying that they would, and 36% of participants are telling us that they wouldn't, and 26% unsure. Look, I think it's quite sort of tricky, isn't it? Because we need to go with the definition. We need to have a diagnosis as it stands. OAT is for substance use disorder, and if you think about it, opioid use, in terms of opioid use disorder, tolerance and withdrawal, if he is experiencing that, if he's taking the medication as prescribed and it's not doing, you don't have any sort of he's not on, so he's not demonstrating any aberrant behaviors, we shouldn't use tolerance and withdrawal towards making the diagnosis of opioid use disorder to begin with. And I think, there are sort of some participants telling us that, OMED equivalence is quite low. I mean, I don't know, it's quite low, but it's low, I agree. And so I think it's, but, he is, what is it? He's on 75 TDS oxycodone. And, since we're so used to oxycodone, we forget that it's actually 1.5 morphine in 1 to 1 oxycodone. So as David said, this is more than 100 milligrams morphine. So the dose is not insignificant, but I know what you mean when we say low. It's not like the ones that we often see with problems. And so, that's I think sort of an issue. And in cases like this, when I'm asked in my pain team or other settings whether OAT is an issue, I think there are things that I need to think about. One is, if he has an upcoming surgery, he's going to have further acute pain, and is OAT going to be a facilitator or a hindrance for his sort of pain review? And all this pain that we're talking about, is this acute, or is it actually a continuation of the chronic issues that he's had and he's been waiting for the operation for a while? I guess, a proper review of the pain is really important. And in terms of types of pains that are mentioned in here, especially hydro is pretty good in terms of non-pharmacological strategies, and increasing the availability of opioids by using non-opioid adjuncts, such as clonidine, is not really a bad idea. And before OAT is in place, I mean, for this type of pain that he's having, is there a place for interventional stuff? Like, are the things that I would sort of wonder when I'm sort of making a decision. And David is actually making a very valid point about opioid-induced hyperalgesia. Remember, Roland is not on opioid maintenance therapy, and I think that's sort of a bit tricky. And Eric's saying that OAT may cause opioid-induced hyperalgesia as well. So that's something to keep in mind. And I think before jumping into, because remember with the previous case, the reason that you couldn't manage their acute pain was about the fact that the person was on OAT. So before locking him in, I think we need to make sure that we've actually exhausted all the other options. And Candice, can I invite you in for some comments, what will come to your mind? And she will regret this so much coming here, and she will never attend anymore. But others won't do that to you, Candice. It's just that I know you. You're muted, Candice. You're still muted. All right, I can see that she's trying to unmute herself. Oh yeah, there you go. You're unmute now.
Sorry, I couldn't get out of the chat. I was stuck.
Yeah.
And what would I do with this guy?
Or like these sort of issues that I he has the I guess he's got the underlying chronic pain issues, but he has some some issues that's going to require some surgical intervention, and these type of patients are not rare. So
look, I mean, I guess my thinking is, if he's not having any aberrant behaviors with his opioid use, does he really need to go on an opiate agonist therapy? He's got an opiate therapy that seems to be working okay for him now. Given that you're about to send him to hospital, people freak out when they see methadone on the chart and they don't know what to do with their pain management. They just tend to do nothing and the poor patient suffers. I think it's probably better off leaving him as he is for now and doing the non-pharmacological stuff and trying to do a prehab before his surgery and that sort of thing.
Yeah.
And optimizing his non-opiate medication. So, and I'd probably, think about it again later once he's got through his surgeries, or is he just going to be one of these patients, and we've seen plenty of them, where they think that surgery is the answer to every pain that they have, and they just keep going and having more and more surgeries. So does he need a pain program? So yeah, it's a bit tricky.
Yeah. So I thank you very much, Candice. I think that's the thing that I would sort of think about this man as I listed in here, and that will be our approach. Like if this man came to our pain clinic, Prince of Wales pain clinic, we would be sort of really considering about non-pain issues, non-opioid interventions, and definitely invite him into our pain program, and encourage him to use non-medication, non-pharmacological approaches. And I would definitely see the upcoming surgery as an issue that probably would, in the absence of aberrant behaviors, by the way, and because we don't have any information for that, I wouldn't go with that. And I can see that someone's talking about medical cannabis. I guess I would definitely repeat what I said, whether introducing another medication at this stage is the option, the right thing, will depend on the evaluation of pain at the time. But obviously, that's a type of treatment that's now commonly used in pain management. So I'm going to move on to the next one, seeing that we don't.
Could I just quickly interrupt?
Sure.
Afa? Sorry, there's just one question you missed that I'd really like to know the answer to as well, is how does clonidine help?
Okay. So clonidine, basically the way that I conceptualize it in my head and explain to my patients, that it sort of enhances opioids action, if you like. It's an opioid sparing medication that we use, and it sort of potentiates, if you like, the effect. In practical terms, Candice, what would you say? Why would we add clonidine in these sort of scenarios?
It works as an alpha-2 agonist. It helps to manage pain from that sort of sympathetic way. It also has quite a relaxing property. So people who are anxious, it seems to relax them, so they're not so worried about their pain. And often it's the worry about the pain is the reason that drives them to take more opiates. So it's quite an effective adjunct.
Yeah, interesting. I always thought it was something for tremor, that it does actually also have a relaxing, like a cognitive relaxing effect as well. It's interesting.
And we see that as an opioid sparing enhancing pain medication. So but obviously please remember it's a blood pressure medication and you're using it as an off-label, and that it is sort of, you need to assess that your patient is suitable. So it's not for everyone. And you need, if you start it, especially, you need to see the patient or check in with the patient a week later or so, so that they're not just falling over.
Alison's putting in the chat, do you find a lot of patients really hate it and fall over?
So, I think, Alison, you're telling us that a lot of your patients are hating it. So in in ones that do they hate it? I don't. We haven't received any sort of strong feelings like that. But yeah, fall is I could say risk, and it needs to be really assessed. So I think that's the way. And then I would say, before monitoring, so before starting it, checking their blood pressure and monitoring is really quite important, because although we use it in our practice for that reason, it is a very effective blood pressure medication. So keep that in mind, please. Yeah.
There's a lot of non-fans of Clonidine in the chat.
Yeah, I can see that, but I actually agree with Frank. Like in terms of withdrawal management, but remember though, we're not actually using it for withdrawal management. This is really using its alpha-2 sort of features for something else, for someone who's on opioids rather than taking them opioids. So you are right, sort of. Whether it really does anything for our patients who are withdrawing from heroin or the last end of their methadone, whether it was ever helpful, there's a big question mark around it. But in this occasion, in pain, we do find it. So give it a go if you have someone suitable. And all right, I'm going to move on to Clara, who's a 56-year-old female, long history of chronic pain after a major vehicle accident, sustained multiple fractures to pelvis, legs 24 years ago, treated with opioid analgesia. The OMED just went up to 660 at one stage, and you know that this happens. I'm not exaggerating. We see more than that. And then her treating GP retired. Her new GP referred us to the local pain clinic. So OMED is reduced to 120 milligrams over the course of 12 months. She wakes up in pain, runny nose, watery eyes, taking more than prescribed, running out of scripts, requesting refills. Does Clara need to go on OAT? That's my question to you. I really appreciate for you guys filling this poll, and we're almost like around 70% again. Majority of people are saying yes, and that there's 10% who's saying no, and there's 15% saying unsure. So 75% of people said that they would think that is suitable. And I suspect because you've got some first of all withdrawal experience, but also she has some aberrant behaviors, like I guess you might sort of say it, but she is in opioid withdrawal, obviously, and an opioid withdrawal is associated with increased pain. So I think that's really important, and that needs to be acknowledged with her. And the issue of opioid hyperalgesia was brought in earlier on. So, and I think there is this raging debate about the place of opioids, long-term opioids, for chronic pain. I don't know that we'll ever have a consensus on this issue, but if you look at any guideline coming from here, from the North American countries or European countries, you're going to find that consensus is, there's no place for opioids for managing chronic pain. But having said that, you can see that this woman cannot actually cope without it. And also we've seen what happened in the United States when people were taken off opioids. It's really associated with terrible outcomes. If you cut people off opioids, and that there are increased overdose or suicide or death, but definitely terrible outcomes. So in theory, it is fantastic, if people can get off opioids. But in practice, as you can see with this woman, she is an opioid withdrawal. And if you take her off, it reduce her dose further, she's going to get sicker, and you're going to lose definitely any contact with her. And there are chances that she's going to be sort of be disadvantaged. So before Steve steals my thunder anymore, I'm going to go and ask the question for everyone. Given that 75% of you thought that OAT is appropriate, what would you prescribe to her?
And we're nearly hitting the 60% mark. So lock in your answers, everyone. If you've got a few more responses, that'd be great.
All right. This time we had less people putting their hands up for this, but 68%. No, it's actually not bad. That's fantastic. Thank you very much. So basically, the majority of people are telling us that almost 98% saying that buprenorphine in one form or other, and then the opinion is split whether it's depot or sublingual. And then there's one person who thinks methadone is an option. So look, I think the way that I think about it is, I would, there is one more step before maybe this, and it might be appropriate for her. It may not be. That's potentially Fiseptone, but it might complicate things as well. Fiseptone is oral methadone. It's for pain, and you definitely require authority. You need authority for it. And since it comes in a tablet form, it might be, you can actually do sort of BD or TDS. But I think her history and how she was going on, whether she had any overdoses and what type of aberrant behaviors that she had would determine whether she's suitable for Fiseptone. I'm just putting it out there because it's methadone is a good painkiller, in fact, and it's full agonist. It's got the NMDA receptor effect and etc. But in reality, I definitely agree with Steve and David, who have been sort of talking about buprenorphine. That's been our experience in our clinic, that we have transferred quite a lot of patients from very different backgrounds and very different sort of pain experiences, successfully transferred to buprenorphine. Some stayed on oral. I think it's a bit of a habit because people tend to take pills when they have pain and having their takeaways and taking it. I think there is a behavioral component to it, and eventually we sort of work them to depot, because in my experience, depot buprenorphine has been quite effective for the same group of people as well. And I sort of think that there's someone who said that there was not an option for all of the above. I think that's what it's said. Yeah, and that is true because all of them are valid. We just need to think about only issues for putting someone on methadone liquid, that you have to remember the number of takeaways that you can give and the restriction that's going to bring to their lives, whereas with Suboxone they don't have that. But if they are really benefiting from the full agonist action, you know, it's still a valid option as a treatment option. But can I just remind you all, the bits that we discuss in OTAC course, that patient choice is also incredibly important. So what we think is a part of the discussion, but anyone going on OAT, I think we just have to put all these options, what's available to us, to them as we know it, and then sort of guide them through the decision. And if you have significant concerns, I don't know, like QT interval or previous overdose history and etc., you could maybe talk about it. And but it's really important that they're on board. And so I think you know, it's a really important thing that we sort of give option. And Steve's talking about something which is very pragmatic for someone who is on shorter acting opioids, no different than heroin. Remember your guidelines, that you can actually directly induct someone onto long acting if that's their choice, and you can sort of fiddle around the edges the first few weeks, whether you're going to give an extra dose or you're going to give some sublingual. That's the thing. And I guess, you know, don't discount the sublingual bib in this case, because, you know, given that this person has been on a lot of opioids, do your safety check, but you can go to very easily weekly takeaways with this person, because, you know, they were taking a month's medication supply with no issues. So just keep that in mind. But I would say the main determinant will be the patient choice for these options. And I sort of, I'm just going to thank you all for really participating very actively, and all the wisdom that you shared. I'm hoping that you follow the chat as much as I did, because there was a lot of helpful information there. And I just think that, you know, in pain, and I know that getting into a pain clinic is very difficult. There's waiting lists and etc. But we believe that, you know, cognitive restructuring, you know, sitting down with the patient, breaking the pain experience down, the nature of the chronic pain, where opioids fit in and what can be done. We think that is incredibly important, and that sort of helps with the process. And there is a lot of evidence behind it. And in a GP practice, this may be difficult, but maybe booking in some long appointments and breaking the issue down, because we're talking about chronic pain, right? Most of the time, we're not talking about some acute issue. For acute issue, they deserve exactly what everyone else deserves if they're on that. Frank's talking about something that I always feel like it's patients coming to addiction doctors. And yes, Frank, you have to see their faces when they meet me in the pain clinic, and when I introduce myself as like one of the things that I do is pain addiction. I don't get lots of smiles and butterflies and you know, like bluebirds flying out of the room at that time. But I guess we also have the skills to discuss certain aspects of this experience better. So I think there is something that we can bring into that. But it's a shame that they would only end up with addiction doctors, because they do deserve that. All right. So I guess we were 3 minutes before, and thank you very much. And I hope this was helpful or was worth your time. Thanks.
Wonderful. Thanks for that, Apo. Would you be able to just go to the next slide for us, and we'll do a quick wrap up? Just very briefly, as you all are aware, we do have the relevant sections in the New South Wales OTP guidelines if you want to have a look at them there. When we do post the recording on the website, we will of course include links to that. As always, a lovely reminder as well about support services and other services that you can access, in particularly SafeScript New South Wales, as well as the 24/7 hotline such as DASIS, and also your local alcohol and other drug service. If you want us to help facilitate you getting in touch with them, more than happy to. So feel free to reach out to our team if you would like assistance with that. Otherwise, you can click on those links or scan the QR codes And of course, the slides will be sent out, so you don't have to quickly scan the code or scroll that down. And just on the next slide, Apo, which I think is the final one. Thank you. So, of course, firstly, a big thank you to everyone here who has contributed to this evening's session, but a big thank you to Professor Apo Demirkol for helping to facilitate this presentation.
And also thank you to Candice Wallman for being
and to Candice as well, yes.
for being my victim in this one. Thank you, Candice.
Thank you, Apo.
Will she return? We don't know. Maybe, maybe not.
David.
And as you know, we do run these monthly, and our next webinar is actually on the identification and management of QT prolongation, presented by Dr. David Yu on the 7th of November at 6 p.m. Sorry, I somehow accidentally muted myself. And I'll post that link into the chat right now. And I would also just mention we do have another webinar at the University of Sydney Specialty of Addiction Medicine that is separate from the OTAC program. It's called the Sydney Addiction Seminars, and we do have an upcoming talk later this month on de-prescribing opioids, titled Finding the Balance with a big question mark. Once again, I do wish to really highlight that this is separate from the OTAC program, but managed by the group that I work in at the uni. And we do seek funding, small amount of funding each year from various institutions and companies. And this year it is funded by Indivior. So just as so that everyone's aware and to acknowledge that conflict of interest. But in any case, those links are both posted there. And as a reminder as well, if you ever have any clinical questions or cases that you wish to have presented in an upcoming session or a topic suggestion, that would be great. There was one person who actually just sent through a topic suggestion in the chat to me privately. So thank you very much, Frank, for that. And finally, of course, if you go to the OTAC webinars page, we have all of our previous recordings, so you can check those out there. Other than that, I think we've hit 7 o'clock on the dot, so we're keeping to time, which is fantastic. So I will let everyone go for this evening. And once again, thank you everyone for contributing to the session.